everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and today our speaker is Dr. Ben Thrower, whose topic is men's health and MS. We will address all questions and comments after the presentation is over. Dr. Ben Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as Medical Director of the Holy Family MS Center in Spokane, Washington. And Dr. Thrower is the Senior Medical Advisor for the Multiple Sclerosis Foundation and enjoys contributing to our quarterly magazine. We're pleased to have him join us to present this important topic. Dr. Thrower, thank you for being with us this afternoon, and I'll turn it over to you.
Great, thank you. And thanks everyone for joining in. As always, thank you to the MS Focus staff. You guys are amazing. We thank you for putting these events on and letting us get some information out. So we're going to talk a little bit this afternoon just about some specific men's issues in multiple sclerosis, but I'm going to start kind of broadly with some overviews, and then we'll finish up really with some issues relating to men's sexual health. And I think, when we think about MS and health overall, there's a tendency when you have a health issue like multiple sclerosis, sometimes for people to get very focused on just that MS. And I think there's a period of time when people are newly diagnosed where that's probably appropriate. But as time goes on, you want to realize that MS is not the whole story of your health life, that it's part of your health picture, but obviously you can have other health issues. One of the things we like to remind people is with MS is that MS doesn't tend to kill people. People with MS don't tend to die from MS. They tend to die of heart disease, cancer, and stroke. So you really want to put MS into the context of the big picture of your health and not get tunnel vision with just that MS focus. There are comorbidities or other health issues that people with MS deal with, and some of these things are much more common in men versus women with multiple sclerosis. Men with MS are 48% more likely to have hypertension. They're also at higher risk for diabetes, hyperlipidemia, anxiety, and depression. And when you look at women with MS versus men with MS, men are more at risk for all of these things than women are with MS. So depression in multiple sclerosis, especially in men with MS, there are some differences, and this is across all men with depression, not just men with MS, but depression. So men tend to manifest mood changes sometimes a little differently than women do. Men are much more likely to abuse substances, to turn to alcohol or a prescription or street drugs to help sort of numb some of that pain. Depression can be harder for others to recognize because guys aren't always as good about reaching out for help. There's sometimes a stigma attached to depression. And so it's this, attitude that I've got to tough it out and just pull myself up by my bootstraps. One of the ways sometimes that depression will manifest in guys is rather than becoming very withdrawn and sad looking, they tend to become more irritable and labile. So snapping at friends and coworkers and relatives, road raging, if someone just cuts you off in traffic can be some of the early signs of depression in men with MS. And most importantly, men are much higher risk for committing suicide with depression as opposed to women. So there are some differences between men and women with multiple sclerosis. While women are more likely to have MS by about a 3-to-1 margin, men's symptoms are sometimes a little different. They may start later in life. Men are more likely to have primary progressive MS. It's sometimes been said that men may follow a worse course with their MS. And I think that that's a little bit misleading. If you gave me a 35-year-old man and a 35-year-old woman, both newly diagnosed with relapsing remitting MS, and the only real difference in their presentation is their gender, I don't know that there's really that much of a difference in how people progress. I think what has led people to suspect that men may follow a more aggressive course is the fact that more men have primary progressive MS versus women. So testosterone is the major sex hormone in men. So a lot of focus has been placed on female sex hormones and how women do with pregnancy, how women do postmenopausally. But there are hormonal components to men's MS as well. About 40% of men with multiple sclerosis do have low testosterone levels. And we think testosterone is important in the immune system. Low testosterone has been associated with worsened measures of physical and cognitive disability in MS. And some of our early studies have suggested that getting men's testosterone levels up into a good normal range does seem to have effects on long-term disability. We have to balance those potential benefits out with potential risks. And so as testosterone levels go up, there could be a higher risk of cardiovascular disease. So we do check testosterone levels pretty commonly in men with MS. And if we find that they're low, I encourage them to work with an endocrinologist so we can balance that risk-benefit ratio out of you know, how hard should we push with testosterone replacement. So shifting now to sex, and I found this interesting as I was putting things together for this. These are quotes from a sex therapist, psychotherapist who works with both men and women with sexual issues. And I think the importance of sex for men is different than it is for women. And this is a generalization because there's obviously a wide spectrum of sexuality in both men and women. But in general, for men, you can say sex is more begins in the body, whereas women it really starts here with the mind. For men, sex is almost like a hunger, an energy. And some men do equate sex with love. And so it's also often been said for women, it's the opposite. They equate, you're going to have to be in love first before the sex comes along. I love this quote from Mae West that sex is an emotion in motion. And I think there's a lot of truth to that. I ran across this quote as well, that sex is perfectly natural, but not naturally perfect. So I think sometimes between movies and television and media, both men and women get this sort of unrealistically high expectation of what it should be, when in fact it's, you know, it's two people coming together, and there's a lot of biology and a lot of emotion. So things are sometimes not perfect, and we have to be okay with that and realize that what's right for you know, a couple is what works for them. There's no, you know, what's right for one couple may not be okay for another couple. So thinking about the male sexual response, so this is kind of the sort of the phases of the typical male sexual response. So we tend to start with the sex drive itself, the libido, leading then to an erection, leading then to an ejaculation, or actually the pushing of the sperm, the orgasm itself, and then sort of what we call detumescence, so sort of, well, letting the air out of the balloon at that point. And then there's typically a period in men where they have a kind of a refractory period where they're sort of a little bit more fatigued. They wouldn't probably be able to have another erection or orgasm for a period of time, a refractory period. That refractory period varies a lot. You know, the movies would tend to make it think that it's very short, when in fact, most guys, they're probably out of commission for a little bit, maybe more so as we get more mature. So what is the actual physiology of an erection? So what this shows is kind of the plumbing system. And what I would encourage you to think of with erections is a plumbing system and an electrical system. So the plumbing system is the arteries and the veins. So what happens is the arteries are pumping blood into the penis. Then what happens is the veins are actually going to constrict and not let that blood flow out. So then you end up with an erection. The electrical system has control over that. So you have to get signals from the brain via the spinal cord to say, that's the libido part, to say, okay, go ahead and start this plumbing process, the arterial flow in, the constriction of venous structures to not let the blood flow out. So, you know, in theory, we would think multiple sclerosis would primarily be an electrical problem. It's going to be important when we start looking at a lot of the therapies for erectile dysfunction, because those really work on the plumbing system for reasons I can't explain necessarily. Even though MS is an electrical problem and not a plumbing problem, a lot of these therapies still work beautifully in men with multiple sclerosis. So when we think about health conditions that might affect the plumbing system directly, you think about things that cause you know, atherosclerosis, so diabetes, hypertension, smoking, those sort of conditions. So when we think about sexual dysfunction in men with multiple sclerosis, we can divide it into primary and secondary. So primary sexual dysfunction would be directly related to the damage in the brain and spinal cord, that damage to the myelin, the damage to the nerve fibers, not allowing those signals to get down to the penis to have a sort of an erection or orgasm. And then we have secondary issues related to MS. So if you've got spasticity, if your legs are really tight, you know, if you're having spasms, you know, while you're trying to have intercourse, that's going to be a problem. Decreased range of motion can make it difficult just for positioning. Pain during sex is going to be a little bit distracting for people. A lot of folks worry about their bowel and bladder symptoms. So, you know, having potential incontinence, sometimes it's going to affect your sort of perception of body image and can be something that leads to a lot of fear and anxiety and can certainly affect sexual functioning. So this was a study of not just men with MS, but just across a large group of men. And it looked at lifestyle factors that, you know, outside of multiple sclerosis that could potentially affect sexual functioning. And this was a big study, almost 350,000 men. Cigarette smoking and physical inactivity had a dose-dependent effect on erectile dysfunction. So the more you smoked and the more inactive you were, the more risk you were for erectile dysfunction. Healthy diet was associated with a lower risk of erectile dysfunction. With alcohol, there was sort of a paradoxical, you know, response in that moderate intake of alcohol, which in most guys would be defined as about 2 ounces of alcohol per day, was associated with a lower risk of erectile dysfunction. When you went above that, you had a higher risk of erectile dysfunction. Fortunately for coffee drinkers, there was no effect of caffeine on erectile function. So how could MS potentially affect sexual functioning for men? Well, there are changes in body image and roles. So, and this is probably true for both men and women with multiple sclerosis. So if you're challenged with mobility issues, that's going to maybe affect how you see yourself physically. If a guy with MS is no longer working, maybe he's requiring some assistance from his care partner. How do you make that shift from lover, husband, spouse to, okay, I'm someone who needs some help with certain activities? How does the care partner make that shift in roles? How does that person go from, you know, okay, at one moment I'm the loving spouse and now I'm sort of wearing the nursing hat, and that can be challenging for some people to make those shifts from one role to the next. Decreases in sexual desire or something that we see, difficulty with erections, and then delayed orgasms. We're going to go into each of these areas and talk about some potential treatment options and strategies. So when we think about erectile dysfunction, MS or not, the first things that come to mind are the oral medications. So your Viagra, Levitra, Cialis type drugs. All of these drugs fall into a class of what we call phosphodiesterase inhibitors. Now, if you go straight down, I don't know if you can see my arrow here, but straight down, we've got the blood vessels. So what phosphodiesterase inhibitors do is they help the arterial side open up more so that you're getting more blood flow into the penis, so more flow in. They're not really affecting the venous side, but they're getting more blood flow in. These drugs, interestingly, so Viagra or sildenafil, when you think back on how it was discovered, it was not originally meant to be an erectile dysfunction drug. It was being used to treat pulmonary hypertension. So you were opening up the vessels in the pulmonary arteries. And when the drug company was doing the studies on this, what some of the men started reporting back as an interesting side effect was much better erectile function. So it was an interesting side effect, not what the drug was designed to use, that ended up being who knows how many billions of dollar drugs. All of these drugs are fine. The sildenafil or Viagra has gone generic. So whereas it used to be crazy expensive, is actually now in the 20 milligram pill. You can get it for as little as $1 a pill. The dosing, some guys will do fine with 20 milligrams. Some men may need as much as 100 milligrams of Viagra to see an effect, but at $1 a pill, it's certainly a lot more accessible than it used to be. One of the important things to remember if you're using sildenafil or Viagra is that it is an incredibly food sensitive medication. So you want to have an empty stomach when you take this drug. And a lot of guys forget that. They'll have a nice date night with their significant other, have a nice dinner, and then go home and immediately take their Viagra dose on a very full stomach. And there's a good chance you're not going to see the full benefit of the medication. Ideally, you'd like to take Viagra 2 hours after or 2 hours before a meal to see the most benefit from it. There are other medications, the Levitra type drug, the Cialis, not as food sensitive. A lot of guys like the Cialis, the tadalafil, because it's not quite as time sensitive, so it has about a 36-hour duration in a 20 milligram dose. So if you took 20 milligrams now, you've really got the next 36 hours to work with. There is a 5 milligram daily dose on Cialis. It is FDA approved for prostatic hypertrophy. So you'll have guys sometimes getting kind of a double benefit using it to treat prostate sort of urinary hesitancy, but also then using it for potential erectile dysfunction. Prostaglandin type injections. So this now is on the you can see the to the bottom right of your screen. There's a cartoon of a gentleman doing an injection towards the base of the penis. There are certain things when we describe them to guys as treatments that usually generates a "I don't think so" response. This may be one of them, but we do have a lot of guys who, once they get past that initial psychological thought of doing a shot into the penis, are saying, this works, it's okay. So the injection is done right before sexual activity, and it has a pretty high success rate. This same prostaglandin type therapy has been developed into an intraurethral suppository. So top right of your screen, you see this, that's a little bulb, if you will, and within that is a tiny little pellet of prostaglandin called the Muse system. And so you squeeze that bulb, it basically puts that pellet into the shaft of the penis, where it's going to then have the same effect as an injection. Sometimes we get that same "I don't think so" reaction when we describe this to guys, but again, we have people using this and really getting a lot of benefit from it. So these would, if you have erectile dysfunction, again, what's interesting with all of these are technically working on your plumbing system. And MS really is more of an electrical problem, but we do have guys with MS who do really, really well with any of these options. So what's one of the potential side effects of these types of drugs? Sometimes they work more than you want them to. So this is the 4-hour erection that just doesn't want to go away. It may sound like a good thing, but after about the 30 minutes of it, and you realize it's just not going away, it can be a problem. The reason that we pay a lot of attention to this is this called priapism. This prolonged erection that won't go away can actually be permanently damaging to the nerves in the penis. So what we don't want guys to do is think, well, if Viagra is good, maybe if I put Viagra and Cialis or Levitra together, what if I took all 3 of them? Wouldn't that be amazing? It would be an amazing trip to the emergency room. So it's not a good idea. And we do have guys that have done this. When we describe what the treatment is for this it's usually just a discouragement to doing this. They actually have to drain the blood from the penis with an injection to get that blood out. And again, if you ever have this, take it seriously, because it can cause permanent damage. So this is another treatment option. So these are vacuum pumps. So basically what this is doing is you're using the vacuum pump to draw the arterial blood into the penis, and then that black ring at the base of the penis is acting like the venous constriction. So you're drawing the blood in, then putting that ring on to not let the blood go out. So really simple, risk-free thing to do that can be a good adjunct for erectile dysfunction. Sometimes if testosterone is necessary, depending upon the levels are. And this testosterone therapy really applies probably across all of these treatment options that we're talking about. If you have low testosterone, we want to get that addressed regardless of which of these treatment options we're looking at. So this is an interesting one. Now we're getting into the probably more aggressive treatments for erectile dysfunction. So this is a semi-rigid penile implant. Basically, it sort of almost clicks into place, if you will. So when not in use, it's in the folded down position. When you're ready for use, kind of click it into position. I love this urologist quote: "Spare the rod and spoil the wood." Again, in the appropriate patient, this could be a good treatment option. Along the same lines is the inflatable penile pump. This always makes me think of the Nike Air pump tennis shoes that you could sort of pump up to an appropriate fit. So this again is surgically implanted sort of little inflatable rods here. You can see these two kind of long white skinny devices, and then hooked up to a pump in the kind of lower abdominal area. So basically, when you're ready to use this, you're just going to push on that pump in your abdomen. It's going to inflate that device and be ready to go. And then there's a mechanism to release that pressure from the device. This is kind of future potential. This is fascinating. If we can pull this off, I don't know where they're at in this testing right now. Again, this would be a surgical procedure where they're implanting a soft, sort of cigarette-like rod, if you will. It's going to be soft in its natural state. It has an sort of a coil at the base there, where you see the stem of the banana, if you will. And a magnet then is placed over that device. It sends an electromagnetic pulse that's going to generate just a low level of heat. And with that heat, that device is going to expand and become rigid. So as long as the device is warm, it's going to be rigid. Once the guy is done with that, he puts a cool wet flannel cloth over the penis, and it's going to cool that device down, and it's going to go down into the sort of the more natural flaccid state. So don't know where that was testing, but it looks like it would be fairly user friendly if they can pull that off. So what about delayed orgasm? So this is having intercourse and just going and going and going and not being able to achieve orgasm. We can see this in both men and women, and it is more common with multiple sclerosis. There can be psychological factors. So a guy has this happen once, and then they get kind of anxious about it, and it's almost a self-fulfilling prophecy going forwards. Excessive alcohol. There's a slang term, whiskey blank, that describes this. So the guy can get an erection, but he's just not going to be able to have an orgasm because of having too much alcohol on board. Number of medications can do this. So our antidepressants, and these are the common antidepressants. So your SSRI type drugs, Prozac, Celexa, Lexapro. The older SSRIs, like your Prozacs, have a higher risk of this than some of the newer ones. I would say with Celexa and Lexapro, the risk is much lower. Drugs like Wellbutrin actually carry no risk of this, or bupropion. And sometimes, so if a man or a woman is having issues with delayed orgasm on an SSRI, but their mood is great, we just have this one problematic side effect. What we'll sometimes do is add a little bit of bupropion or Wellbutrin to their SSRI just to get rid of that side effect, and it can work very well. Some antihypertensives, antipsychotics, and anticonvulsants can have this side effect as well. So what are the treatments for delayed orgasm? Well, if you're on one of the offensive medications, trying to get rid of that medication if we can possibly, or add something to help counteract it. There are medications out there that can actually help. So amantadine is an old anti-influenza drug that we sometimes use for fatigue and multiple sclerosis. And the energizing effect of amantadine, it's actually a side effect of the drug, one of the other side effects, it can sometimes help with delayed orgasm. Buspirone and then cyproheptadine, which is a muscle relaxant. If there's a psychological component to sort of help people get past that sort of mental block, counseling can be of benefit. And I think one of the important things too is a lot of times as men, we are very goal oriented. And so if we think of intercourse, we think if we don't have an orgasm, if we don't have our significant other have an orgasm, then we have not completed the job and this was not appropriate. Sometimes we have to step back from that expectation and say, sometimes the journey itself is more than is a bigger deal than the destination. So just in realizing you can enjoy sex even without an orgasm. I put this little picture down here in the corner, that little black ring device. So this is basically like a vibrator for men. And so it slips onto the shaft of the penis. And what it's doing is it's providing intense vibratory stimulation to the guy. I suppose in the right position, it could probably be for the woman as well. So what this is going to do is try to help you push past that delayed orgasm by giving you more than just the normal sensations of intercourse. You're getting this intense vibratory stimulation also. So that can be a helpful device. So with that, I am going to stop talking at you guys. I wanted to just kind of give you the big picture of, kind of not focusing on just your MS. Take care of yourselves. Get your routine health maintenance things. Get your PSA checked when you're supposed to do it. Do your colonoscopies when you're supposed to do it. Touch bases with your primary care provider to get just routine health maintenance. One of our jokes here at Shepherd Center is if your neurologist is your primary care provider, you have a bad primary care provider. That is not what we should really be doing. We're here to help be a part of your comprehensive team, but you really should have a primary care provider working alongside us. So why don't we open it up to questions and see what you guys want to talk about?
Thank you, Dr. Thrower. Thank you. So to our listeners, there are two ways to ask questions. You can either type them into the chat box or use the raise hand feature in the app. If you are on a mobile device and you'd like to use the raise hand feature, please click the screen to pull up the menu and select more, which is the icon with 3 dots, and we'll unmute you and an alert will appear on your screen asking if you'd like us to do that. And David, I see your hand raised, so I'm gonna lower your hand, and I can't see you to unmute you because I'm on a phone myself, but if you can unmute yourself and you can speak directly with Dr. Thrower.
Hi, Dr. Thrower.
Yeah.
Great presentation. I have a question, a comment and a question. Wonderful presentation. Now, my question is in regards to prostate examinations. I really do not want to do a prostate exam. I was diagnosed with MS 14 years old, and now I'm 38. I don't want to do prostate exam. And I know that the doctor said you're supposed to do it at 40. But has that age increased to about 50 or 60? Please give me some hope here.
Yeah, so the great news for you is that really you don't have to get the finger up the butt anymore. So now they're generally going to do just a PSA, a blood test. So I was unaware of that. I had a physical exam recently, and I've been a couple of years, and I went in all prepared for the indignity. I know for our hostesses here, we got nothing to complain about compared to what women go through. We get it, easy, but it just got easier because now they're generally doing PSA, just the blood test, and not the finger. So yeah, so go get it. They'll just do a blood test. And yeah, if they come at you with a finger and some KY, say, hey, can I just have the PSA, the blood test?
All right, that's good. Thank you.
Sure thing. But before that had changed, we always said, it's really important if you're a guy that you want your primary care provider to have small hands.
Yeah. Oh, I see Kay Welsh has her hand up. let me lower your hand and you are free to unmute yourself.
Hi. So I have a two-part question. My husband took the Viagra, and he felt like he was having a heart attack, and his face got really red, and his heart was beating. So that didn't last long. So he did go on the sildenafil, the Cialis, and that did help with the bladder and the dribbling, because sometimes he, with working long hours, he worked in a hospital setting. You can't go to the bathroom when you want to go to the bathroom. There's a case going on. So it was really challenging. And it seemed like all the other people, even if they didn't have MS, all the men had issues over the age of 55 with going to the bathroom, trying to drink up water and go to the bathroom. So, but his thing is, so when we are intimate, he'll be okay for like 5 minutes or four, maybe it's 3 minutes. And then he's just so exhausted. And it's like the timing and everything. And then he's like, I have to sleep now. And then he'll sleep. And then it's like, okay, maybe a little bit later. So a lot of times we try to be intimate, but it just doesn't happen. So if you look at us with a marriage, maybe we've been married like 20 years, we're considered a sexless marriage because he just can't make it there. He just gets so tired. So I don't know what to do about that. And he tried taking caffeine pills or trying to figure out morning, night. He's just always so exhausted. And then the other part of my question is, what do you know about like more natural things, such as pumpkin seeds? I told him to eat raw pumpkin seeds, and I was just trying to do stuff with nutrition and zinc and different things. But I don't know if it's just hodgepodge. But anyways, those were my two questions.
Yeah, great question. So on the first part, so people with MS, men and women, can have fatigue, and fatigue comes in kind of two versions. You've got the non-exertional fatigue or lassitude, which just is, and then you've got exertional fatigue, and sex is certainly a form of exertion. So as people with MS raise core body temperature with exercise or with sex, sometimes they get what we call nerve fiber fatigue. So areas of old damage in the brain or spinal cord where the myelin has been stripped away, those areas may stop working very well. And so if he's not been on a medication like dalfampridine or 4-aminopyridine, so we think of dalfampridine or Empira as the walking drug, and that is what it's FDA approved for. But the older version of that drug, 4-aminopyridine, which does exactly the same thing. These are all drugs that work at potassium channels on demyelinated nerve fibers. We never thought of 4-aminopyridine as the walking drug. We thought of it as the drug that could help with any sort of exertional or heat-related symptoms. So we've had people start 4-aminopyridine just to see if it would let them exercise, including having sex, more effectively. The response rate's about 40%. So 4 out of 10 people with MS are going to get a good response from it. 6 out of 10 people are not going to get anything from it. So 4-aminopyridine is not FDA approved. It's made at a compounding pharmacy. So your neurologist would just write a prescription for it, find a compounding pharmacy. Down at, I don't know how many people on the line are from the Fort Lauderdale area, but one of the better compounding pharmacists for mail order is actually in the Fort Lauderdale area, Skips Compounding Pharmacy. They've been working with 4-aminopyridine forever. Ideally, you'd like to use a pharmacy that has made this medication before. There were a couple of cases many years ago of inexperienced pharmacists making this drug and causing some pretty bad side effects. So I'd be nervous if it's someone that's never worked with it, but if it's an experienced pharmacy, it's not, because you're using the non-FDA approved version, typically insurance is not going to cover that. It should call, I think Skips, it was in the, I don't know, $50 a month range, thereabouts. So I would look at that. I would also think very significantly about cooling strategies. So we know people with MS function better with exertion if the ambient temperature is lower. So I know you kind of think about sex, you like to think about having the room nice and warm, but this may be one where it's better to have it on the cooler side because the guy may function better with that cooling. Drinking super chilled liquid, something with the consistency of like a Slurpee or a slushie right before sex, can actually help drop the core body temperature. So that may be a help as well. On the natural, I don't think there's any harm in trying those things. I think the hard scientific data is not great on them, but sometimes, you know, it may be that something like pumpkin seed, horny goat weed, you know, tryptophan, you know, each of those things may have a little bit of benefit, so that, you know, taking you know, them in combination, maybe. When people are trying different therapeutic approaches, I like for people to probably try one thing at a time. So maybe do the cooling strategies and the 4-aminopyridine. I would put those together, so you're addressing the nerve fiber fatigue. Try that for a month and see what that does. You know, if that's not of benefit, then maybe shift toward being aggressive with the more natural remedies. Try that for a month, see what it does, just so you're very methodical about what works and what doesn't work. Also, if you had side effects with something, you know what did it.
We have 2 questions. I see Jim and I see Greg. Jim, I'm going to lower your hand. You can unmute yourself, and Greg, you'll be right after Jim.
Hey, Doc. Obviously, the implants are going to be affected with your MRIs. So how would you, if somebody has done that or looked to that, you'd have to take into the thought process of, is it really worth that versus being able to get your MRIs to stay on top of your MS? You have to take that into consideration.
So great question. So the semi-rigid that's sort of the click in place, that is MRI compatible, and the inflatable is MRI compatible. That other device, the one that you would heat and expand, I don't know on that one because that's not FDA.
Well, I wouldn't think that, because you said it was magnetically switch activated, so the MRI magnetic field would be turning it on.
That could be a problem.
That would be a problem.
Yeah. So I would doubt that would be MRI compatible. But the semi-rigid and the inflatables, are MRI compatible. You know, I think now when you look at any surgically implanted devices that are out there, people are trying to be very cognizant of MRIs, because MRIs, it's done not just in MS, but so many other health conditions. So a lot of, even some of our electronic devices like the bladder stimulators and intrathecal baclofen pumps, those are MRI compatible with a few caveats and some, a little extra preparation.
Yeah, I'm scheduled this Friday is my next vaccine, and the next Friday is my MRI. So I'll be back down your location next 2 weeks from now.
Awesome. We'll see you soon.
And Scout definitely looks sad to see you leave this morning.
You're talking about my dog. Yeah, our dog gives me sad eyes. The big Shiloh Shepherd. Whenever I leave for work in the morning, she gives me the guilty look.
Good to see you. I appreciate you doing this.
Thank you.
Greg, you can unmute yourself and speak with Dr. Thrower whenever you're ready.
Hi, doctor. How you doing tonight?
Good. How are you?
Oh, I've got a question about the dalfampridine or Ampera.
Yeah.
So the question is, what is the maximum dosage that I go off of the manufacturers on the bottle saying that, it shouldn't be more than 2 per day, 1 every 12 hours. Is there a different amount of dosage that you could use?
Yeah, so it really looks like that is the maximum dose that we should use. So we were part of the dalfampridine studies back in the day, and we did look at higher doses, and you really didn't see much benefit. What you did see was a higher seizure risk when you went to higher doses. So yeah, I wouldn't go higher than the 10 milligram twice a day recommended dose.
Okay. The other thing was a question you had mentioned. We were talking about Viagra as far as helping. One of the big side effects that I get from a Viagra is it's not the accelerated heart, although that's an issue also, but I end up getting a headache afterwards. So I end up having to take Advil beforehand. Yeah. And I also noticed that it's not anywhere near as effective, and sometimes not effective at all, if I'm taking my sertraline, which is the mood medication also. So I usually, if I know that we're going to have a date night, then usually a day or two ahead of time, I will have to actually stop taking the sertraline, but it's not, I'll watch my mood at the same time. I'm on a very low dosage of that.
So because all of those, the oral medications, the Viagra, Cialis, Levitra drugs, they are vasodilators. They're getting more arterial blood flow down into your penis. They can provoke headaches in a susceptible person. So that's a real deal side effect. You could, talk to your doctor to see if maybe adding a little bit of Wellbutrin to your sertraline, because a lot of times that will block the sertraline effect and let you be able to stay on your sertraline continuously and just take a low dose of Wellbutrin or bupropion with it. It may block those sexual side effects and the blunting effect of the Viagra.
Okay.
Yeah.
Yeah, I the dosage that I'm on of the sertraline is, I'm on like 20 milligrams is all very, very low dosage.
Tiny dose.
It's more actually to distract me from bawling because I saw an ant get squished or something, for lack of a better term.
Yeah.
But I watched, like I said, I won't go more than 2 days off of it. So
Yeah, so if you're someone that gets away with a really low dose of sertraline, you probably would take a really low dose of the Wellbutrin, bupropion. So like a 75 milligram dose would probably be gracious plenty.
okay, thank you.
Yeah.
We have two questions in the chat. The first one comes from Kay. She asks if New Vigil or Pro Vigil helps with intimacy energy issues if he takes it beforehand.
Yeah, so Provigil and New Vigil, are drugs we use. Some of my favorite drugs for lassitude, so the non-exertional type of fatigue. If the person has just generally low energy levels and they're nodding off, then Provigil or New Vigil are definitely going to help with that. So they don't do anything directly from a sexual, good or bad from a sexual standpoint. But if the person is tending to nod off and they're really sleepy, it can certainly help there. I think, along the same lines, most people with MS have, high energy and low energy times of the day. So trying to, plan sexual activity during your higher energy times, that sometimes it's, it requires some lifestyle changes. A lot of people think of, like your date night, where you're going to have your date night, dinner, movie, a sexual intimacy afterwards. Sometimes we have to shift things up a little bit and think about, maybe more of a morning time activity when most people with MS have higher energy levels.
Our next question comes from Scott. He asks, how would you know if you have a primary progressive MS? Do lesions show up on an MRI?
Yeah, so if you go online and you look up McDonald criteria, so the McDonald criteria are the strict guidelines that we use to diagnose MS. So there is a McDonald list for primary progressive MS. So typically primary progressive MS, again, more common in men than women. It's our only form of MS that's more common in men. It's usually going to start in a middle-aged guy, and it's usually primarily a walking issue. So there are no relapses typically with primary progressive MS. And a typical story would be, it's a guy who maybe he has a physical activity. He jogs a couple of miles a few times a week. And now he starts noticing that whereas he normally jogs 3 miles, now at 2 miles, he starts noticing his foot drop a little bit. And the next year, his other foot's dropping a little bit. And now it's at 1 mile, and now it's at a half a mile. So it's just this kind of insidious, slowly progressive issue. Primary progressive MS is more of a spinal cord issue than a brain issue. So some people with primary progressive MS don't have a very abnormal brain MRI. They can certainly have abnormalities. Most of the demyelination is going to be in the spinal cord, and it can be subtle. I have a lot of guys with primary progressive MS who really only have 1 or 2 suspicious looking lesions in the cord. Spinal fluid may be helpful, but the spinal fluid is only abnormal in about 50% of people with primary progressive MS. So the the thing we're looking for in spinal fluid is called oligoclonal bands. These are antibodies that are produced in the spinal fluid, but not in the blood. So if we have the right story and we see, you know, oligoclonal bands in the spinal fluid, that's the icing on the cake. But not seeing them doesn't rule out primary progressive MS. Most people with primary progressive MS, I would say, don't have to have a spinal fluid exam, but if you're in doubt, it can be a, you know, a potential tiebreaker to make the diagnosis.
We've got 3 questions. I'm going to go in order as they came. Donald, I'm going to lower your hand and you can speak directly with Dr. Thrower. I'm not sure where he went. If he comes back, if you do decide to ask your question, Donald, just unmute yourself. But Jim and Greg, you're up.
Well, Doc, you mentioned the other things for the energy. Have you seen any contraindications with Adderall, with the amphetamine salts?
And so we would be probably the only really serious contraindication to stimulant drugs like Adderall or Ritalin, things in that class would be if you had uncontrolled hypertension or maybe significant cardiovascular disease. People with extreme anxiety, we want to be a little careful about with stimulant drugs because sometimes make their anxiety quite a bit worse. But outside of that, you know, really not any direct contraindications. I would say if all things were equal, I would probably prefer a Provigil or Nuvigil for fatigue and MS. As many of you may know, one of our biggest roadblocks to using Provigil and Nuvigil in MS is lack of insurance coverage. That technically there is no FDA-approved treatment to manage fatigue and MS. Lassitude. Now again, the Ampera is more for the nerve fiber fatigue. But lassitude, just the general tiredness, there is no FDA-approved treatment option. So by definition, everything we use is off-label. Insurance companies don't care if we use something that's cheap and off-label. So amantadine, probably even stimulant drugs like Ritalin and Adderalls, they're not going to give you a hard time on it. If we try to use an extended release stimulant like a Adderall XR, a Vyvanse, which is going to be more expensive, then your insurance company's probably going to push back on us. They always push back on us with the Provigil and the Nuvigil.
I did the Ampura, which I didn't really notice a difference on that. I tried that for a while, and the pushback I was getting through Medicare, off topic, they don't want to pay. So that's how I ended up with the Adderall, which does seem to help with the cog fog and getting me going, but just didn't know if there was cross problems with that and the subjects that we're discussing.
Nope, so not a bit.
Okay, good to know. Appreciate it.
Yep, sure thing.
Greg, I'm lowering your hand and you can unmute yourself again.
Hey Doc, you just mentioned that the primary progressive, you hit a key on there where you were saying a spinal cord. So I was able to stop my lesion progression years ago using rituximab before Ocrevus was available and before rituximab was even approved by the FDA for MS. It had been approved, but I was having to pay out of pocket in order to get the injections. But it brought to mind, you were saying that primary progressive is primarily in the spine, and it could be something with the spinal fluid. Is that something that possibly, has anybody looked into bone marrow transplants of some sort?
So, you know, the bone marrow transplants, or HSCT, hematopoietic stem cell transplantation, it got a lot of new information, new research coming in just a few years ago. You had stuff coming in out of Canada. There was a trial out of the UK. If you pick the right person for bone marrow transplant or HSCT, it can be tremendously effective. I don't think primary progressive MS is the right target though, because what we really see with HSCT is it's a great anti-inflammatory treatment. It gives you a new immune system, a very non-inflamed immune system, and there's just not as much inflammation with primary progressive MS. Now, that's not to say people couldn't get some benefit from it, but if you look at the big centers in the US and Canada that are doing research on HSCT, are pretty picky about who they let into those trials. What they've almost exclusively looked at is people under the age of 50, relapsing remitting MS, and very active relapses and or new inflammatory lesions on MRI. Part of the reason you want to be thoughtful in who you select for HSCT is we've come a long ways, but it's still not a risk-free procedure. It is high-dose chemotherapy used to wipe out your existing immune system before we give you a new immune system. So there's a good 1 month period where you have no immune system, and any little bug that comes along could be potentially fatal. And I would say that again, they're doing much better now. When HSCT first sort of came to the MS world back in the 80s and 90s, the mortality rate was in the 5% range. It's pretty close to zero now.
Okay. Yeah, I mean, other than my legs arguing with me constantly, I actually love my superhuman immune system that I have.
Yeah.
I just need to get my legs to work with me.
So funny backstory on Rituxan with primary progressive MS. So Ocrevus is our only drug that's approved for primary progressive MS. Rituxan has the exact same mechanism of action, but Rituxan failed its primary progressive MS trials. And so when you talk to the guys behind the scenes, so I was good friends with the medical director at Genentech who was running the Rituxan trials, and he shared with me that if you looked at all the Rituxan data, there was one research site that had some data that was just a little outside the norm. If you took that one research site out of the trial, it was a positive trial. It kind of makes sense because we know Ocrevus met its endpoints for primary progressive MS. It only makes sense that Rituxan would work as well because again,
I think the only difference was one was from an animal genetic strain, correct?
so Rituxan is what we call a chimeric monoclonal antibody. It's part mouse and part human, whereas Ocrevus is a fully humanized antibody. It's kind of a laboratory concern that in theory you could say, well, humans could react to the mouse antibody and make antibodies to the antibody and make it less effective. It was more of a theoretical concern. We never saw it in the real world. We saw patients on Rituxan who are doing great. There's a cousin of MS called neuromyelitis optica that Rituxan's been the go-to drug for that condition for forever, and people do very well with it. So yeah, we're happy with Ocrevus, Rituxan, the generic Rituxan, Truxima, the new B-cell therapy out, Kesimpta. We think they all work really well.
All right, on those same lines with Rituxan and Ocrevus, now, since my lesions have not progressed since 2008, is it beneficial for me to stay on Ocrevus? I mean, it's not remyelinating, and I'm not really seeing a positive turnaround.
So,
but with MS, it's so heat sensitive and all, and I'm in Florida, and it makes it very rough to keep track anyway. So
we always need to remember kind of what is our goal with Ocrevus, Rituxan, Tysabri, any of it doesn't matter whether it's primary progressive MS or relapsing remitting MS. So we're trying to prevent new lesions on MRI. We're trying to stop progression or at least slow it down. And relapsing remitting MS, we'd like to prevent relapses. We don't expect those drugs to make anything better. And it's so different than anything else we do in medicine, because normally in medicine, you expect something to get better. Your blood sugar, your blood pressure, your pain, something gets better. Whereas with these drugs, they're more like an insurance policy for the future. You will talk to people on highly effective therapies like Ocrevus and Tysabri and relapsing remitting MS who do get better. And we're thrilled when that happens. That's icing on the cake when that does happen, though. Honestly, we don't know why that happens. It may be that we do such a good job of stopping the MS process that you let natural repair mechanisms sort of come into play and remyelinate and reverse disability, but we don't think the drugs themselves are directly remyelinating. So I think if you're stable on Ocrevus, I would tend to probably want to.
Well, I haven't done Ocrevus for 3 years. Rituximab, I stopped in 2008. My MRIs look exactly the same as they did in 2008. What's progressing is the effects that I'm having. So,
Got it. So, and real, we're starting to understand also that MRIs, they're a great tool, and we will continue to do those as part of MS monitoring. But as a lot of you probably know, they can be disconnected from how you're doing. So we see individuals who say, I know my pictures haven't changed, but I'm changing. And we believe you. We know that can happen. That can happen because as good as MRI is, it's not telling us the whole story. There are levels of damage with multiple sclerosis that we're just not fully appreciating. So we've always talked about MS as being a white matter disease, which it is, but it's also a gray matter disease. And that gray matter pathology is a little harder to appreciate on standard MRI. We also are coming to understand the concept of loss of neural reserve. So you can injure your brain or spinal cord to a certain degree and get away with it. Doesn't matter if you injure it with MS, stroke, trauma, you can get away with injury to a certain degree. As we age, we lose neural reserve. Our brain does not tolerate injuries as well as we get older. So you can have old MS lesions that were below the threshold to show any clinical symptoms. So they were below your neural reserve. But as we get older and we lose neural reserve, that lesion that was or area of damage that was asymptomatic can now become symptomatic because you don't have as much backup. In that situation, your MS has not changed one bit. That lesion hasn't changed any. Your ability to take that hit is what has changed. And that MRI is not going to look any different in that setting.
okay. I'd love to keep going with you, but I see that Donald's put his hand back up. So sorry to take everybody's time.
Donald, you can unmute yourself and speak directly to Dr. Thrower. Thank you for hanging in there. Oh, Donald, I don't know what's going on.
We still can't hear you, Donald. Sorry, maybe you could type your question in chat.
We actually do have one more question from Christian. I hope I'm saying that right. Who asks why men with MS have a lower testosterone level.
Yeah, that's a good question. And I honestly don't know the answer to that. So it may be, as we start to understand more about the kind of the hypothalamus pituitary endocrine axis. So a lot of our endocrine function in both men and women, ultimately goes back to the pituitary, the master endocrine gland, and the pituitary is regulated to a certain degree by the hypothalamus. So it may have something to do with disconnections between those. That's a hard thing to see on MRI, but that would be my sort of hypothesis, is that it's something along that axis has been disrupted, so the pituitary is not getting the normal sort of input that it should to tell guys to produce the testosterone that they should.
And I do see a question from Michael, and it looks to be our last one, who asks if you could explain neuroplasticity.
Yeah, so neuroplasticity is kind of along the same lines of neural reserve, so but a little bit different. So neuroplasticity is the ability to reroute around an area of damage. So let's say you put an MS lesion in an area of the brain that controls strength to your right leg. Well, neuroplasticity says, you know what, I don't have the capacity as a human to remyelinate that yet. Maybe I can't make new nerve fibers, but maybe I can just form new pathways around it. We see this in action. There have been studies that have looked at people with severe relapses with MS, and one group was treated with IV steroids in our typical fashion. The other group got IV steroids plus rehabilitation. And in both groups, they did functional MRI studies to see what areas of the brain were lighting up. The group that got physical therapy after a severe relapse, as opposed to just steroids, actually had better clinical outcomes. So they recovered better. They also showed what looked like some evidence of neuroplasticity on their functional MRI. So they were using other areas of brain to compensate for what that damaged area was not able to do at that time.
Oh, Greg, I see you in the chat. Okay, so our last question is from Greg. Oh, wait, no, he's just asking if Donald could unmute himself again, or I'm not sure.
Can you hear me now, or?
Yes, we can.
Okay,
Yes.
I found the right button. How's that? My question is about spasticity and testosterone. I've had MS for 6 years. About 4 years ago, I was starting left foot drag. And then with diet and no medications, my symptoms have improved. And my foot drag stopped and things like that. But I did have prostate cancer 20 years ago. So that's a non-issue in the whole thing for me. Questioning whether testosterone levels would be affected because I no longer have a prostate and MS, if that's all working together, because no one has really given me a good reason. My neurologist, physical therapist, and medical doctor of why my spasticity is acting up.
So it's important to remember spasticity is the result of an old injury to the brain or spinal cord. So it evolves over time. So if everything else is stable in a person with MS and spasticity is the only thing that's really changing, so there's more extensor tone in a leg or more flexor tone in an arm, that really is not something, that's not due to a lesion that just happened. That's due to something that happened a long time ago. Probably one of the greatest examples of this is if you look at someone with a stroke. So early on after a stroke, let's say it's a stroke that left the right side of their body weak. Early on after stroke, they're going to be weak and the muscle tone is actually loose. As you follow that person over time, months and years, you're going to see that arm wanting to contract up and the leg wanting to stiffen out. So spasticity evolves over time as a result of an old injury. So I've not seen anything specifically about how testosterone affects spasticity directly. In the disability studies, they were looking more at like the EDSS, the disability measure, which is it has a spasticity component in there, but it's kind of diluted out by everything else that's in there. My gut feeling would be that testosterone would probably tend to help more with cognition, with strength, with endurance, things like that than with spasticity. I wouldn't say it's impossible, but I think we probably do a better job managing spasticity, with things like aggressive rehabilitation, range of motion, medications if we need to, baclofen, tizanidine, cannabinoids, your medical marijuana type options that are out there. So probably, that's not to say testosterone isn't important, but I don't know if testosterone is going to be the answer for spasticity.
And just to follow up to that, what I find, I have less strength in my upper legs. That's where my big loss of strength has been. And that was even before I really had diagnosed with MS. And so that's partially what I'm describing with the spasticity too, that I also have. That's a big loss in my upper legs area.
So I think separating out true weakness from spasticity sometimes is not easy. So a lot of people with spasticity will describe their legs as being heavy or feeling weak, when in fact it's extensor tone. Their legs, their foot is being driven into the floor by that extensor tone, so it's harder to walk, harder to get your foot up off the floor because there's a tendency to want to drive that foot downwards. And you can have both. You can have both spasticity and weakness. One of the things I really like to do with spasticity is get people in with physical therapists to have them help us decide how much of this is increased tone and how much is weakness. Because If I blast someone with enough baclofen, I can probably get their legs loose. I may actually worsen their function though, because they may be using a little bit of that extensor tone to help compensate for underlying weakness. So that's again, I think why we have to realize that you may have some of each, and working with therapists to help us judge how much of each are we dealing with is helpful.
And I think there's a couple other issues that I have a curvature of my lower spine too, which is worsening with old age and things like that too. So it's like everything is coming together in one
Yes, and I think
focused area.
You're a great example of how the MS doesn't exist in isolation, and if you have spinal issues, so spasticity is notoriously stimulus responsive. Anything that throws you off your game, a shoe that's not fitting appropriately, a urinary tract infection, a viral infection, low back pain, those things are going to make the spasms worse. Even constipation and a full bladder can make spasticity act up.
It looks like we've answered all the questions, which is good. But that's all the time we have for now. If you guys missed any part of this conference, it will be replayed on msfocusradio.org, our SoundCloud page, and the Multiple Sclerosis Foundation YouTube channel. And please be sure to follow us on Facebook, Twitter, and Instagram for times and access information. And our next conference will be next Thursday, April 22nd at 1 p.m. Eastern Time with Katie Burgess, who will cover inflammation, diet, and disease, food solutions. So we thank you all for participating. This was a hot topic and it was very informative. So thank you, Dr. Thrower.
Absolutely.